Good morning again. This is Zayed Meadows. I'm going to be leading the discussion today. We'll be discussing knobology and physics. I'm going to go ahead and get started in the essence of time and out of respect for each of you. So I know we'll probably have some others that'll join us, continue to join us as I'm talking. I've put up the QR code for your credit. We're going to move on. Today's agenda, we're going to talk about the equipment controls as it relates to transducers, resolution, intensity, and power. Artifact, we'll discuss the Doppler equation, the use of the equipment, and then documentation and orientation with relation to the exam itself. When performing a diagnostic ultrasound, I'm sorry. Okay. When performing a diagnostic ultrasound study, the transducer you use will dictate the type of study that you have to do. If we were doing a carotid evaluation, we would pick a transducer with a mid to high frequency range. Whereas if we were looking at the aorta, you pick a transducer with a lower frequency. This is the same notion for our lower extremity exams. We would pick a transducer that has a range of a mixture between the lower and higher frequency ranges because of the size of the limb. So based on the limb size, if we have a larger limb where those vessels are deeper, then we're going to target a transducer that has a lower frequency. We have a smaller limb, the vessels are more superficial. We want to target a transducer that has a higher frequency. Our current transducers have the ability to do what we call multi-hertz. That means they can function between multiple frequencies. Through the use of one of the keys on the system, we can change that frequency. It allows us to choose the higher frequency that's needed for more superficial vessels or a lower frequency that is better for deeper vessels. Low frequency is going to give you better depth penetration. However, you're going to get more attenuation. That means loss of the energy in the signal. It also equals a decrease in the B mode and Doppler resolution. So these are often things that have to be considered when you're choosing the frequency of probe that you're going to use. A higher frequency is going to give you better B mode and Doppler resolution, more attenuation of the signal, and a decreased depth penetration. As I stated earlier, most transducers have the ability to multi-hertz their frequencies. So meaning you can use the same transducer and you can lower the color or spectral frequency with that same transducer. A lower frequency will improve the resolution of deeper structures. So you can see here in the upper left-hand corner, with the use of a 4 megahertz probe or frequency, it's difficult to appreciate the color of this renal. Here we can see the renal vessels at 3.1 megahertz, a little bit better with color. Continuing to reduce the frequency, we get a little bit more color absorption at 2.5. And our best color absorption is at 1.8 when looking at this renal vessel. So again, because of the depth of the kidney here, bringing that transducer down to the lowest frequency has allowed us to get the best color absorption with this image. There's a trade-off in ultrasound. You can have better image resolution, which is your axial resolution, by having the duplex unit process the return signals for a longer period of time and thereby reduce the frame rate. The frame rate is the number of frames shown per second. The number of frames per second is measured in hertz, which is your cycles per second. The more frames per second, the more the image will look like a movie. Therefore, it won't be choppy. It'll look more like a real-time evaluation. The lower the frame rate, the more it looks like you're in a room with a strobe light. It will look choppy and move in slow motion. The lower the frame rate, the choppier the image, but the better the resolution will be. The unit has a longer time to process the return signal. The frame rate is also affected by the depth from which you are looking. The deeper you look, the more time it takes to process. The slower frame rate is also affected by the size of the sample volume. This here is your sample volume with color and pulsed. So we can see the box that is around the vessel here. That's our color box that represents the color sample volume. The more focused the sample volume, the better the frame rate will be. This is a linear array transducer. This essentially is our workhorse probe. It's used for most vascular studies. These transducers generally have a frequency range of anywhere from 3 to 15 megahertz. These transducers give you better resolution, and they're typically used for extremity venous exams, carotid exams, arterial extremity exams, as well as small part exams. This is a curved array transducer. It has a lower frequency. It's used mostly for evaluating the abdomen. For vascular studies, we typically use this transducer for aorta, inferior vena cava, visceral, and arterial evaluations. However, if you have someone with deep vessels in the lower extremity, the curved linear probe can be used to increase your depth penetration. If using this probe, and it has a multi-frequency capability, utilizing this probe at its highest frequency setting can help to improve depth penetration as well as resolution. Here we're talking about compound imaging. We can see here that the image on the probe on the left illustrates fundamental imaging. There are renal calculi producing acoustic shadowing. On the right, the probe and image illustrate compound imaging. Compound imaging electronically steers the probe, or the ultrasound beam, excuse me. Gathering data from additional lines of sight, it adds that information together, which is known as the compounding component. The image thus providing some image of the deeper details as it relates to the calculi. While the image on the right has better resolution, shadowing from the calculi is eliminated, and someone reading this study could overlook the critical finding because they weren't looking for shadowing and didn't see it. So the point with this is sometimes on our ultrasound systems, we have the options to turn features on and off. So sometimes you have to turn certain features on or off to see how the image may look in order to improve the image and in order to demonstrate important details that may need to be shown. When the transducer is stimulated, the center frequency is of concern. However, there are harmonic frequencies. These are frequencies that are complete octaves above and below the center frequency. Harmonic imaging processes those return frequencies as well and overlays them on the other images, producing a smoother image and improved axial resolution in most cases. Harmonics can smooth out and improve image resolution. However, sometimes turning off the harmonics brings out additional information. In vascular, it's preferred to see images more contrasty, where they have less shades of gray. We like to see edges rather than subtle changes in the tissue. So turning off the harmonics may improve the contrast. Intensity is how much power is concentrated in a particular area and is usually measured against how much time the beam is concentrated in a particular area. Focus in the amount of power will affect the intensity. The AIUM released a statement many years ago stating that there have been no reported bioeffects when the intensity is less than or equal to 100 milliwatts per centimeter square. A bioeffect is damage or alteration to cells. The bioeffects of ultrasound are heat and cavitation. Heat is known as the thermal index, which occurs from the friction of the cells due to sound passing through the tissue and moving the cells. The higher the intensity, the more friction, the more heat, and the more likely cellular damage can occur. Cavitation is known as the mechanical index. It occurs when the sound wave separates the cells as the wave passes through the tissue. For short bursts of time, a little cavity is created. The damage may occur when the cells slam back together after being pushed apart by the sound wave. While intensities that are used in the vascular lab are not likely to create a bioeffect, we still make sure that we utilize the ALARA principles as low as reasonably achievable is what that stands for. Attenuation is the loss of signal amplitude due to several things. It could be absorption. Air, bone, and tissue will all absorb sound by converting it to heat. It may be scattering. When sound hits a small object, it will go in many different directions, most of them not back to the transducer. Reflection is another one. When sound hits an interface that is not perpendicular to the path from the transducer, it will not reflect directly back to the transducer. There's also refraction. When sound hits a tissue interface with a different impedance, the sound beam will bend, taking longer to return to the transducer. And then there's strong reflectors. Bone and calcification do not allow the beam to pass through. The beam is not able to pass through and be returned from deeper structures when there are strong reflectors such as bone or calcification. The effect of attenuation is artifact. Shadowing, mirror, distortion, reverberation, ring down, these are all forms of artifact. These are all things that as a technologist, as you're studying, if you're taking your RVPI exam, these are all things that you should be familiar with and recognize. One of the easiest ways to minimize artifact is to move your transducer or reposition. If you're imaging from an anterior plane, If you reposition your transducer and come in from a more lateral approach, if there is truly an artifact that is seen, that artifact will disappear when you move to a different position. Here, if you notice the specular reflections off of the tibia, this is the tibia here. Remember, bone is a strong reflector and we can't see through bone. This is your tibia. And see, this is the great saphenous that's measured here, and we get reflections off of the tibia. While the tech that was doing this image is demonstrating their area of focus is the GSB, this image still could have been improved greatly had this person insonated from a different angle. So again, by repositioning, changing angles of view, it will help improve artifacts that are seen in the images that may in turn take away from the area of interest that's trying to be demonstrated. The overall gain, whether it's B mode or Doppler, boosts the amplitude of the return signal. This is known as post-processing. Therefore, no extra power or energy is used on the patient. So if you think about it being like a radio in your car, there's a radio tower from which you're getting a signal. As you drive away from the signal, it becomes harder to hear due to attenuation. And if you remember, those are things such as depth, absorption, scattering, or reflection. So you turn up the volume, which is our gain. When you turn up the volume, not only can you hear the song on the radio, but you will also increase the amount of noise that you hear too. So at some point, as there's more and more attenuation of the signal, you hear more noise than you do song. So it's no longer a discernible song. Well, this happens with B mode and Doppler, and as well as color Doppler. Because it's all sound, this is what can happen with attenuation. Time equals depth. It takes 13 microseconds for ultrasound to go 1 centimeter in soft tissue. Our ultrasound units know how long it took to get the return signal and display the signal on the screen at a certain depth. The TGCs boost the signal, or our gain, from a particular depth, which is the time, to improve the image. Typically, the signal in the near field, which is the area at the top of your image, needs less gain than that of that signal from the far field. And that's deeper. That's the deeper area of your image. But with different impedances and acoustic enhancement, one must adjust the TGCs instead of the overall gain at times to improve visualization. So you can see these keys here by the image. These represent the TGCs. So if you all look at your ultrasound machine, when you have a moment, you'll see these keys. By adjusting these keys at different levels, these will adjust the gain on your image at those various levels. Beginning here from the most superficial aspect of your image down to the deeper aspects of your image. Here you can see this is an image on the left that has too much gain. It's oversaturated. That's why we see it so bright and grainy. The area of interest, it's difficult to appreciate what is really trying to be shown here. This is an image of a carotid, internal carotid here. And there's calcification along the walls. But with so much gain, it's hard to have respect for the calcification that's seen here on the intima of these walls. Here on the right, there's too little gain, so you can't see anything at all. So the weaker echoes that may be represented in this image can't be seen without adding more gain. So there has to be a balance between how much gain is utilized so that you're not oversaturating your image and taking away from the area of interest. But on the flip side, you're able to show and demonstrate what is of interest and needs to be seen. In the image on the left, while the gain is high, we see here with the spectral, and there's a lot of noise in the background. The tech would not be able to make out the actual signal very well if the gain was not that high. However, on the right here, the Doppler signal is strong. The gain here is too high, causing a mirror artifact. So we see a mirroring reflection of the spectral waveform here because of this gain being too high. So in this instance, by turning down the gain, because the true signal is so strong, we can better appreciate the true signal and still be able to, it can still be demonstrated because of the strength of that signal, but reducing the mirror artifact by turning down that gain. Here, just demonstrating our ultrasound systems. We have various ultrasound systems that each of you may have encountered throughout our clinics. This is just representation of one of the many systems that we have. This here being the ultrasound P6, P5 system. Here we have our pneumatic cuff inflators. The pneumatic cuff inflators are critical to our practice in that while these scans can be long for the sonographers, for yourselves as you're trying to learn these exams, the pneumatic cuff inflator gives the flexibility to the sonographer in that it will automatically inflate and augment the vessels while they're scanning. So it prevents the sonographer from putting themselves in compromising positions that can contribute to musculoskeletal injury and things of that nature. Very important to be mindful that when doing ultrasound scanning, that you want to be ergonomically sound, making sure that you're positioning yourself properly to prevent those injuries. Sonographers are, the statistics show 90% of them are scanning in pain. So it's very important. You see your sonographer looking like a contortionist and in an awkward position, just to remind them, be careful, make sure you're positioning yourself properly so you're not in pain, because those factors are real. So again, this device here, the pneumatic cuff inflator, does help to prevent those awkward positionings for our sonographers. The cuffs and the probes that we use, it's important that we properly clean them. I think this is very common sense. After each exam, it's necessary to clean and disinfect the equipment. There is certain cleaning agents that have to be used with the probe. There are alcohol-based cleaners that will strip the membrane off of the probe if used too frequently. So we try to avoid those and stick to the recommended cleaning products. Taking care of the probes is another key thing. You're utilizing the ultrasound probe. If you're in a procedure, your technologist is not there with you, somebody's not there to manage that probe for you, make sure you're not just tossing that probe. These probes have crystals in them. These crystals are easily broken if the probe hits something hard. If that probe falls to the ground and hits the ground, it can break the crystals that are inside this probe. And if that happens, you can put as much gel as you want on that ultrasound probe. You will have blackout in your images. You will get wherever that crystal cracked, in that space, there will be a dropout in your image, so you'll see nothing. So I know this was to discuss cleaning, but I wanted to add that in, to be mindful of management of that probe so that it's not getting hit up against anything or dropped. Image orientation is critical, especially when the exams, the images that are being demonstrated are being done by technologists and being overread by our physicians. Orientation is critical so that they have a knowledge of what is being demonstrated. And sequencing is something else we'll add to this in a moment. But when imaging in a transverse plane, on the probe, there is a notch. There's a little bump on the probe. The notch should always be to the right side of the patient in transverse. If you're in a sagittal plane, that is when you're holding the probe essentially perpendicular to the lower extremity, to the limb. In a sagittal plane, that notch should be pointed towards the head of the patient. So in transverse, if the notch is pointed to the right side of the patient, the left side of the screen will represent the right side of the patient and vice versa. When in a sagittal plane, with the notch pointed towards the head of the patient, the head is going to be to the left of the image and the feet are going to be to the right. We also try to properly orient our spectral, our Doppler signals. Antegrade means properly directed. It means that the flow is going in the proper direction, the correct direction, not towards the transducer. Retrograde means improperly directed. So it's not going in the right direction. It's not away from the transducer. With our images, we always try and orient the signal that we're receiving so that arterial signals are demonstrated above the baseline, which is this line here, and venous signals are demonstrated below the baseline, which is the yellow line you see. Labeling is just critical to help give representation to the image that we are showing. Technologists should never type diagnosis on the screen. So if an image that's being demonstrated is truly of a DVT, technologists, we try and steer clear of diagnosing. That's the responsibility of the physician. So while I know it's a DVT, while I know that's thrombus, I know it's insufficiency, terms such as non-compressible or echogenic or reflux are terms that we try to utilize when describing the findings. These are more acceptable terms where they are pointing out the findings rather than interpreting and giving diagnosis to what's being seen. One critical thing is, especially for physicians when you're reading these exams, is the labeling and the position of that labeling. Putting the labels in places where it covers the image is not optimal because it can distort those findings that may be trying, that are trying to be demonstrated and seen by the reading physician. Having the label in a consistent location is critical. It makes it more difficult to see when that label is in one place on the image and is moved to another. This is the label right here. So this image is representative of the common carotid artery, the proximal segment. But if you look here and I click through here, you'll see that the label is moved each time in each image. And it takes you a moment as you're looking at these images to find that label and know what's being represented here in the image. So if you're labeling, try and keep the label in a consistent spot on your image so someone that is reading or interpreting that study can better move through the study and identify what you're trying to demonstrate. In this image, the trachea is on the left side of the screen. The trachea is midline, and the proper orientation in transverse is the right side of the patient. However, it's on the left side of the screen and vice versa. So the operator has the probe backwards in this situation. So again, this is where proper orientation is critical when doing ultrasound. Sometimes flow direction can be confusing as well. The ultrasound systems have a button on them. It's called invert. It allows us to invert the color, invert our spectral, but that's not always proper in utilizing that key. So if we have a patient that has insufficiency and the flow is being demonstrated above the baseline, clicking that invert key, while it changes the demonstration of that flow, doesn't necessarily change, it doesn't change the direction of that flow. It just changes how it's being represented. So again, sometimes the flow direction can be confusing. The head to the left of the screen, the feet are to the right in sagittal. The color flow direction and spectral direction are showing that the flow toward the probe is a positive direction. That means the flow is coming toward the transducer. This would mean that flow is from the head to the feet, which is actually retrograde. What the operator did was they did not properly invert the image. So at first glance, if you were looking at this, you might think that the flow is normal, that this is the normal direction of flow. Here, the deflection or the flow is coming toward the transducer. So this would mean that the head of, excuse me, I thought I switched the screen. The top left image shows the actual correct direction of flow. The head is to the left of the screen, the heart is to the right. So with the box angled towards the feet, so you can see that the direction of this angle is towards the feet. The head would be in red, but there's retrograde flow here, which is why we see this carotid artery. Arterial should be represented in red color. We see it in blue because the flow is retrograde. In this bottom right image, the operator improperly inverted the color. So they inverted the color and changed it to red. When in actuality, that flow is retrograde, so should have been represented as it is here in the upper left-hand image. So by the operator changing this color, it can cause confusion to the reviewer. So that's why it's critical with ultrasound to understand the direction of flow, understand the utilization of your color map, which is what you can see here, and what that helps to represent when you're looking at the waveforms and the color of your images. In venous study, the flow direction is integral to providing appropriate information about reflux. In this study, given that the patient's head is to the left of the screen and the feet to the right, the color and spectral display would need to be inverted to show the normal directed venous flow below the baseline. So in this case, the blue in the color is going from the head to the feet, which is retrograde. And the flow above the spectral baseline is going from the feet to the head, which is known as antegrade. So the reflux is actually the flow below the spectral baseline. which is away from the sample volume. So in actuality, this here is the reflux. This is the normal venous flow here. This again is just representative of sequencing. When doing an ultrasound exam, it's critical to stick to the same order of imaging. So when we do our lower extremity exams, we start with the deep vessels up in the inguinal ligament area, imaging the common femoral and moving distally in the lower extremity in order. Jumping around can be particularly difficult to identify what's happening, and very difficult for the person that's having to review the exam when trying to read the study and know what was captured and what may not have been captured. So again, this is just representative of sequencing and not jumping around when doing an ultrasound exam. We can see, just so you know, we can see how long it takes from the time that you pick up the probe until you acquire the last image. So you can see with this study time, if we look here in the upper right-hand corner, it took 11 minutes for this scan for a complete bilateral venous study. So we know 11 minutes really is not enough time, doesn't seem like enough time to really acquire the proper information necessary to give you as the physician the details needed to be able to follow through with whatever recommendations you may need to give to the patient. So it's very important to, we always instruct the sonographers with their timing. There has to be a balance of time. Conversely, we don't want a sonographer taking 2 hours to do a lower extremity exam. But 11 minutes is really too quick, and can be of concern if that's the time that it's taking a sonographer to really do a full bilateral lower extremity insufficiency exam. Mirror artifact, we touched on it a little bit earlier. I mentioned it as an artifact. The problem with Doppler mirror artifact is that the reviewer may not be able to differentiate between the normal flow direction and the true reflux. The operator is capable of eliminating this artifact in most situations. Here we can see the mirror artifact, and because the true signal is so strong, if the operator were to turn down their gain because it's overgain, it will decrease or it will eliminate the mirrored signal and allow just the strong true signal to be appreciated. Angle is also something that is, when taught ultrasound and doing venous studies, angle is not something that is discussed as a critical way of interrogating vessel Doppler flow for a venous signal. However, it's most critical for arterial exams and carotid exams. However, being conscious of your angle of inclination when doing a spectral analysis of flow is critical for venous exam, because it helps to clean up the Doppler signal and eliminate artifact that can be present when the angle is not correct. So it's still, while generally being taught, you'll hear that angle correction is not necessary for venous exam. I would argue that and say that it is, because it helps to, again, give a better demonstration of the spectral flow, eliminating the artifact that can be seen. Key when labeling is to make sure that you're following the standard with your labels, something that is representative of what is being seen and known to anyone who is viewing or reviewing those images. So acronyms, while we know there are certain acronyms in medicine that are utilized for certain aspects of medicine, make sure that those are consistent acronyms that are standard, because what one acronym may mean to you and you type it on your image may mean something different to somebody else reviewing that image. This is just proper labeling and proper demonstration of vessels. Here we see that the gain is not properly set in this image. Better optimization of this image can be achieved by ensuring that we're using the proper frequency. Because the depth of these vessels, because these vessels are so deep, utilizing a higher frequency probe would not be the best choice in this situation. The target would be to have a lower frequency probe and making adjustments to the TGCs so that there is more continuity of the grayscale aspect in this image, but also highlighting the area of interest, which is these femoral vessels that are here, located here. Good representation of here. We can see this is a good, clean, clear image of the common femoral vessel. This is how you want to see your ultrasound images represented. Clean, anechoic. It's black in the middle, so there's no echoes. It doesn't give an indication that there may be thrombus here. And on the opposite side, good compression of this vein here can be seen, letting you know that there is no thrombus, that vessel at this area is free of thrombus. Undergain, again, can limit the ability to see what is trying to be clearly demonstrated. So it's important to make adjustments with the gain so that the area of interest can be properly demonstrated and seen. This is a good image of the perineals. You can see the vein, you can see the artery in between, and here we see the artery after the veins have been compressed. So these are the type of images that you want to look for from your sonographer when you're looking at those ultrasound images. And lastly here, because of the artifact of the bone, the posterior tibial and peroneal veins that are trying to be represented here are poorly appreciated because of the attenuation, the loss of signal here off of the bone. Moving more medial where there's more tissue would have helped to demonstrate what is trying to be shown here and allow it to be a bit better appreciated. So that's the end of my talk. Hopefully there's something that each of you have been able to take away from this. Feel free to reach out to me at any time if there's any questions.
Thank you, Zayed. That was very comprehensive as usual. Much appreciated.
Absolutely.
Do any of the fellows have any questions for Zayed before we sign off?
Zayed, I have a question. I'm Mohammed. The slide that you showed that shows the total amount of time taken to do the scan, this time is presented on the last slide or which slide?
It's represented on every single slide. So from the first image that's taken to the very last image, you can see that timestamp on each of the images.
So how do you calculate the total amount of time taken to do the scan? So,
well, if the scan started at 7 o'clock,
okay, I
with
got
the
it.
first image and the last image has 7:45 on it, then we know it took 45 minutes to do that scan.
Got it. Thanks.
Hey, Zayed, it's Teresa. This was really good. And I think anybody who's going to take the exam, if they look through every single one of those slides and understands them, is going to do much better on their exam. My question is, if the probe is dropped, are you going to necessarily see the damage to a probe immediately, or might it show up a day or two later? What should we do if we drop it and we're worried that we've damaged it?
Good question. So if that probe is dropped and a crystal is cracked as a result, you are immediately going to see the damage. And how you see that is you just put gel on the probe, and you can take the probe and put it down on your arm or your leg. And if you see blackout, a line, a complete black line going down that image, and you've got gel completely covering that probe, then you know you've broken a crystal. If you do that and you don't have any dropout in the image, then you know that you got lucky that time and the crystal didn't break.
Hey, Zayed and Teresa, if I may add, also, as we're using this probe and you sort of alluded to protecting it, if you cut the membrane of that probe, if you do anything with a needle on it, you're also going to see a black line, just because there's always might be a gap there internally with the gel. But that's not necessarily a crystal, but you might get the same kind of picture. Regardless, you messed up the probe.
Great point, Dr. Fernandez. Thank you for that. Yeah, very critical that when you're utilizing ultrasound probes, if you are accessing a vessel and you stick that needle into the membrane, again, you can get the same effect because you cut that membrane. The membrane is the rubber flat portion on the probe. That's what I'm referring to when I say membrane.
So do we just, I mean, we let the tech know, obviously, but.
Yeah, I'm sorry, I didn't answer the second part of your question.
Yeah, I was gonna say, so can they be replaced, or do you have to buy a whole new probe all the time?
So it depends. With some of our systems, we do have, they're under warranty, so the probe can be replaced. Other systems that are on a service contract, we get one replacement a year.
Oh,
So,
okay.
but you'll hear from me if that replacement is happening every 2 months.
You got lucky, Teresa. You got lucky.
Then I will be reaching out to you to have a discussion with you as to what's going on and how we can prevent that.
Well, it hasn't happened, but you know,
I
just
know.
want to know when I need to call Zayed. All right. Forewarned. Thank you.
All right, everyone. Thanks very much. It's 7:50, so time to get back to work. Thanks for the lecture, Zayed. Much appreciated.
You're very welcome. Have a wonderful day, everyone.